Hey, well, welcome everyone. We're going to go ahead and get started. So welcome to the workshop for integrating the hierarchical taxonomy into psychopathology into clinical practice. And we're really excited to have everyone here today and have a wonderful lineup of speakers to talk about how to use the principles from HiTOP in clinical practice. And I'm going to go over some of kind of the ground rules and the schedule today. Okay, well, we're going to start this morning with a HiTOP overview from Roman Kotov from Stony Brook University and Camilo Ruggiero from the University of North Texas and me. And we're going to talk about how to understand the HiTOP model and relevant evidence. And then we're going to discuss benefits and limitations of prevailing diagnostic systems and compare and contrast categorical and dimensional nosologies. Then after a short break, we'll hear from Len Sims from the State University of New York at Buffalo and Catherine Jonas from Stony Brook University, who will talk about scales and instruments and protocols that are consistent with the HiTOP model. And we'll talk specifically about scale interpretations. Then after another short break, we'll hear from Leanna Clark from Notre Dame University and Brady Nelson from Stony Brook University. And they'll talk about integrating the HiTOP perspective, so this dimensional and hierarchical perspective, into case conceptualizations. They'll talk about distinguishing the role of traits and symptoms and how to provide feedback from a HiTOP perspective in a way that can improve client insight and improve the therapeutic alliance. Okay, and then tomorrow in the morning, I should note all of these times are Eastern time. In the morning tomorrow, we'll hear from Stephanie Mullins-Sweat, who will talk from Oklahoma State University, and Chris Hopwood from the University of Zurich, who will talk about how to incorporate HiTOP into treatment planning. So how to identify empirically supported treatments across these spectra and levels of HiTOP, how to develop treatment goals and intervention based on the profiles, and how to monitor and adjust treatment based on feedback from the HiTOP monitoring with HiTOP consistent scales. And then the last talk will be from Craig Rodriguez-Sayas from the University of Michigan, who will talk about working with diverse and underserved populations. In particular, factors that impact the applicability of the HiTOP model for underrepresented groups, as well as contextual multicultural factors that impact scores, how to develop individualized case conceptualizations with a focus on context through identity intersectionality, and then how to recognize the importance of being mindful about stigma and how it may manifest cognitively and behaviorally across cultural minorities. Each of the presenters throughout the workshop today and tomorrow will save some time at the end of their presentation for questions. With this many participants, it's difficult to do that verbally, so we're asking everyone to enter their questions either through the chat or through the Q&A feature, and I will monitor those and make sure that the presenters are aware of them. So with that, I'll turn it over to Camilo and Roman to talk about an introduction to the HiTOP model.
All right, so this will be a review for most, but I think still important information for us to cover quickly. So the whole impetus for creation of HiTOP consortium was that enhance HiTOP model was that existing manuals, diagnostic manuals, have several serious limitations. They are categorical in nature, yet empirical research indicates that none of them are true categories. When we look at latent structure, time again and again, we find continuous distributions with no zone of rarity between pathology and normality. And this categorical approach has been argued for as improving communication. It's easier to use the dimensions, it is thought, but in fact, if you properly use DSM, you have more than 300 categories to consider, and typically a given patient gets assigned multiple codes, multiple comorbid diagnosis, which becomes actually quite complicated. DSM-5, to its credit, has been aiming to address some of these issues, such as including dimensional ratings of personality and symptoms in section 3, also, which is sort of the appendix, but it also has some dimensional ratings in substance use disorders, intellectual disabilities. So progress is made, but most of codes, most of the diagnoses are still categorical. And there is also a problem of heterogeneity that just illustrated on one disorder. In schizophrenia, there are 5 criteria, and there are 82 of which are required for diagnosis. There are 85 ways to meet the criteria for diagnosis of schizophrenia. So basically, you have 2 patients with this diagnosis who don't have a single symptom in common. This wouldn't be a problem if the symptoms were actually equivalent. So it doesn't so much matter whether that's symptom 1 or symptom 2. In fact, they're quite unrelated. So in data actually from our sample, a large first admission sample with psychiatric disorders, we have correlations that range from negative to small positive, meaning that this diagnosis of schizophrenia captures people who are very different from each other. That's true for many diagnoses, of course. And then comorbidity, that is occurrence of different diagnoses, is quite rampant in clinical samples. It is for a given diagnosis, between 2/3 to 100% are comorbid with of cases are comorbid with something else. And in community samples, situation is no better, that 80% of all diagnoses assigned are comorbid with something else. And these patterns are not random. For example, major depressive disorder, basically 60% of people with major depressive disorder have anxiety disorder, which is a lot higher than you expect by chance. The specifically odds of anxiety disorder are basically 4.2. But when we look at the relationship between major depressive disorder and substance use disorder, it's also increased, but twofold as opposed to fourfold. And so we could use these patterns of comorbidity to identify optimal organization of psychopathology. More about that later. In summary, we seen in diagnostic manuals proliferations of diagnosis from 100 back in the days of early editions of DSM to 300 to now potentially 450 if you count various subtypes, etc. And nonetheless, not otherwise specified, remains one of the most common diagnoses, most common in some categories, such as eating disorder or psychiatric disorders. It doesn't tell us very much, besides perhaps a cardinal symptom. Yet, despite this catch-all category being overly relied on, we still have numerous subthreshold cases. That is, cases of patients presenting or clients presenting for treatment, and we don't have diagnosis for them. And the catch here, and this goes back to the whole categorical model not being good fit to the data, is that if we will try to capture the subthreshold cases by increasing the number of diagnoses, we likely would also increase comorbidity. And if you are really worried about comorbidity and wanted to decrease the number of diagnoses, then we would increase heterogeneity within each group. It's certainly an unsolvable problem. And so HiDAP addresses this by first taking hierarchical approach that incorporates comorbidity in it. It doesn't, it's not a surprise. It actually does patterns, say, of major depressive disorder with anxiety disorders and substance use disorders. It uses this information to organize psychopathology hierarchically. Then it integrates also traits and states, that is symptoms. Both types of constructs are included. And because syndromes are decomposed, as you will see, into more specific, tightly knit empirically derived dimensions, then the resulting phenotypes, we can call them diagnosis, but in dimensional framework, are more precise, more kind of more accurate and informative. And the way we get there in the HiDAP model is by using kind of construct validation process. that is start using statistical methods such as factor analysis to organize symptoms such that similar symptoms are together, different symptoms are in different constructs, thus both increasing homogeneity of constructs and distinction between them. Oh, that's what we get. This is sort of a basic summary. It is not showing the details. First, we have DSM at the bottom and its disorders. They're not in high-top model. No, rather, we decompose them into the symptoms, into the traits, and then we take those, organize them into this tightly knit homogeneous symptom components and maladaptive traits. Those are put together in syndromes, which are bigger constellations. Syndromes are put together, for example, like a panic attack. Symptoms are put together into larger subfactors and spectra and superspectra, such as P factor or general psychopathology factors. So here, let's just talk about the spectra, the 6 at the very top, to illustrate, because going through the entire model will take a very long time. So internalizing dimension captures depression, anxiety, sexual and eating problems. The basic thrust of it is that this is tendency to experience negative emotions that are either very intense or prolonged. And then thought disorder includes psychotic disorders, eccentricity, disorganized behavior at various levels of intensity, not necessarily frank psychosis. So that's that disconnection, that's poor reality testing and related disorganized behavior. In detachment, we have lack of interest in social relationships, poor expressivity can manifest as negative symptoms of schizophrenia, for example, but also less intense manifestations, say in schizoid personality disorder. Disinhibited externalizing has its compound term in recognition that it is closely related to antagonistic externalizing. They, in fact, form this externalizing superspectrum together. But disinhibited part is primarily reflects kind of emphasis on short-term rewards over long-term consequences. And that includes various attention problems and the inability to control and regulate one's behavior, sometimes leading to substance use, sometimes leading to other negative consequences. So antagonistic involves very aversive interpersonal behavior, lack of empathy, callousness, etc. And finally, some other form is exaggerated, irrational concerns about one's health. So there that's we stop as a summary, but just to say that we can go to much more refined levels, including levels of syndromes and components where we have in the neighborhood of 100 constructs. There is still work to be done, and we are in the midst of doing it, to determining how many of these constructs are actually empirically distinct. The number of candidates was about 160, but we don't think 160 are actually distinct from each other. So we'll probably end up with about 100 on that level. All right, so let me turn it over to Camilo, who will talk about the rest, starting with measures.
All right, thanks, Roman. My name is Camilo Ruggiero. I'm a faculty member, a professor at the University of North Texas in the Department of Psychology. And I'm going to talk to you today about two things. The first is high-top measures that we have, and the second is my take on general approaches to using high-top in clinical practice. Just as a preview, presenters later in the series are going to get into much more depth with examples about how they use high-top in their practice. So let me start with measures. The high-top consortium, beginning about 2 years ago, began developing a high-top self-report measure. We are in the final stages of completion of that. It should be out in 2023, hopefully no later than May 2023, hopefully before then, but definitely within this year, there will be a new instrument. Currently, there is no single measure that captures all of the high top spectrum as the consortium has outlined. Now, high top is not, doesn't cover every single element of mental health, but it covers a lot of it. It covers most of it. And there's no one measure that really does justice to the entire model. We are hoping that the high top SR breaks new ground there. And when that's released, you can learn about it, either if you're part of our clinical network or if you're part of the consortium, we'll be releasing that soon. It will be made free and available to the public. In the meantime, there are many measures that are high top compatible, that are high top friendly. We have a website that outlines many of those things, like the Achenbach's, the SIBA, the Achenbach system, has youth measures, has adult measures, has been normed in many different cultures, and is consistent with the ideas of high top. The major ones being that psychopathology falls along a dimension, and that there's a hierarchy of how they're related. Those two elements are part of many other kind of instruments that you can use. Instruments such as the PAI were developed in a high top friendly, consistent way. So you're welcome to go to our website and use these measures that we think are more compatible with the high top approach to assessing and understanding psychopathology. The high top clinical translation work group took some of these that we thought did a decent job of covering much of the spectrum and using them, primarily the CAP-PD and the IDIS-2. Now, those aren't comprehensive, so we've added some other measures to cover things that we think are common in clinical practice and important to assess. And so we've created this battery, the high top DAT, which covers a lot of the waterfront, if you will, of the high top model. These are free instruments. The high top DAT is an instrument that we have as a Qualtrics or as a REDCap, and those are freely available. You are welcome to contact Dr. Catherine Jonas to get one of those two, and she'll make that available to you free of charge, and you can use that as a free instrument. Now, it is long, it's several hundred items, but it covers a lot of the high top, and will give you a really great view of the psychopathology without you having to actually administer yourself. It's done through self-report, and a client can do this before they show up to your office so that you have a pretty comprehensive picture as they're walking in. When you administer something like the high top DAT with its different instruments in it that are all free of charge, you end up with a profile of scores along a bunch of behaviors and dimensions. Now, these are the internalizing ones, for example. So you can get a broad view of how the person is doing along many different traits. It's easy to administer for the clinician. It does take time for the client to complete, but you get this very comprehensive picture of a person's presenting symptoms and both behaviors and traits that might be problematic. And what's nice about it is, consistent with the high top model, we track these in relation to community norms. So is that person 1, 2, 3 standard deviations above the norm? Now, there is no single cutoff line that marks person has a disorder, person doesn't have disorder. This is not DSM, where 5 of 9 criteria mean you have depression. High top appreciates that people can have some syndromes that cause problems, as well as much more severe symptoms. So it captures that dimensional perspective. We plot these as T-scores oftentimes in graphs like these, which you can use to give you a sort of profile. Here would be the externalizing and some of the other spectra that are captured by the high top model. Some general considerations when you give a high top like assessment and then interpret it. And so I want to switch gears and to think about how I use these kind of assessments. First of all, it's really important to remember that these are hypotheses. These are not necessarily true. You need to assess the validity of the profile. Like any good clinical practice, you can't simply take a self-report face value. You have to understand, is it a valid profile? What's going on? It needs to be checked against other data, against interview, against history, against reason for a referral, collateral reports. Good clinical skills like that are just important when you're interpreting something like a high top down profile. You can write this up as part of an intake report, and we've done that and have examples. And then you can integrate for therapy. You can track specific traits and maybe re-administer just the items of those traits as you're tracking progress in therapy. If, for example, you're focusing on a specific trait or element of a person's profile. And for therapy purposes, I integrate this descriptively. I would take this profile and descriptively integrate it and tie it to the model that I might be working. Remember, high top is not a therapeutic model. It's a description of psychopathology. So, you would integrate it with, for example, CBT and think about how the presentation fits within your larger therapeutic framework model that you might be working from. I generally think about using HiTop in 3 different kinds of ways, and I'm going to talk about each of these just briefly because, again, presenters will hopefully get into more depth with examples about each of these. But the first way I think about HiTop is just for overall formulation and treatment of symptoms. It's a fundamental shift from a different model. For example, when you're thinking about DSM and you're thinking about categories of disorder, HiTop encourages you to think about psychopathology differently, and its primary ways are by thinking not as a category as yes, no, binary, but rather that there's a dimension of psychopathology, a dimension of depression, from subsyndromal to more severe. Secondly, that these things such as anxiety and depression are not unique and separate disorders, 2 different diagnostic categories, but rather they're related to one another, that they might both fall under the umbrella of internalizing symptoms in this hierarchical fashion. And then finally, you can think about the interrelationships of different traits with a larger spectra, but also at a lower level. And so HiTop encourages you to conceptualize psychopathology in a way that I think most clinicians kind of already do. So it reifies, I think, or reaffirms rather, an approach that I think many working clinicians, no matter what diagnostic system they're using, appreciate in their clinical practice and use. So you can consider, once you start reconceptualizing psychopathology in that manner, you can think about intervening in different ways. You can think about intervening at different levels. HiTop explicitly makes that an option. You can think about broadly focused treatments that might affect all of psychopathology. So, for example, the unified protocol or motivational interviewing, acceptance for broad, diverse sets of elevations. It also encourages you to think about common factors, or you can think about intervening at a lower level. So, for example, this is a meta-analysis results that Wampel did a while back, looking at common versus specific factors in psychotherapy treatments. And we know from work like this and other work that common factors matter, things like alliance. These are things that matter quite a bit in psychotherapy, and they may be working at higher levels of psychopathology, affecting all kinds of traits and symptoms, not this disorder versus that disorder. It's not specific to anyone, that it crosses all. And HiTop's conceptualizing everything as part of a hierarchy allows you to think about, hey, this is working at potentially a higher level of psychopathology. Things like remoralization, which is often one of the first things that happens in psychotherapy. You can think about that broadly affecting psychopathology rather than very specific to a specific kind of elevated trait. The unified protocol we've already talked about is something that can be thought of as broader. Dr. Mullen-Sweat is going to be presenting later. She has a nice paper that thinks about the evidence for which treatments work for different types of spectra of the HiTop model. And this paper here, which you can look for, thinks about, this is from a personality perspective, but many of these personality traits are embedded within the HiTop model. And you can think about which ones work at the different levels of it. She also has more speculative evidence, but provides kind of an overview of that literature. I won't go into this now, given that she'll be presenting for a while. And then, as I mentioned, rather than, in terms of just overall formulation, thinking hierarchically, thinking dimensionally, HiTop gives you that flexibility to focus on first of all, it encourages you to assess the range of spectra. And then it allows you to think about tailoring a very specific treatment to a specific trait. So, for example, behavioral activation is a very specific treatment, or sleep restriction is a very specific treatment. We're working on meta-analyses now that is trying to flesh out the evidence for which kinds of treatments work for which kinds of elements of the HiTop model. I won't get into this much here now. And then finally, the third sort of approach that I use when I'm thinking about HiTop and how to integrate this into practice is using this HiTop map that I have of the different elements and traits and using it to match and think about treatment. For example, you may have a person come in with depression. You can think about different kinds. There's been a little bit of work, not much, but a little bit of work thinking about treatment matching based on other personality traits that are captured by a HiTop model. For example, this is an old work done where patients had major depressive disorder, and the question was, is CBT or medication better? And what this older study found was that For example, CBT worked better in certain patients. For example, if they had high levels of neuroticism, then there was more efficacy of pharmacotherapy over CBT, for example. And you can think about other studies. This is an NVARG study that did a different kind of thing. And I won't get in too much detail there, but the main point is that you can begin using the high top elements outside of the main focus of clinical work to inform what you're doing. So for example, if you have a client that has traits that would lend you to believe that their compliance will be low, that might have you focus, organize your homework differently, even though you might be doing work with them on depression. It will help inform that work you're doing with depression, that maybe you need to spend more time on compliance, maybe you need to do some motivational interviewing to make sure compliance is met, whatever that might be. But thinking about the interrelationship of traits helps you match and tailor treatments to this person's specific treatment. And so HiTop provides this really comprehensive view. Okay, that's all I've got for now. I'm going to turn it over to David, who's going to continue with the rest of the presentation. Thank you.
A couple of things that I forgot to mention at the beginning is that if you haven't filled out the pre-survey that I sent out on Wednesday, and some of you registered after Wednesday may have not received that the first time, I just sent out another link to that, and I'll also put it in the chat in just a minute. And there were a couple of questions that in the chat and in the Q&A. The first being, how long do you anticipate the HiTop SR will take for someone to complete?
I can comment on that since of our small group developing it, I don't think we have anyone else here on. The length of current instrument, and it is going to get shorter, is about 700 items. So it will probably going to get to 450 thereabout. That's a research version. So that's something that is not ready for clinical use, but will be ready by the end of this calendar year, another 2 months, for use in a research protocol where it would take close to an hour. Now, it can be used in modular fashion. So you may be only interested in internalizing, and that will take like 18 minutes, let's say, or you may be only interested in externalizing antagonism and disinhibition, like 25 minutes, etc. Now, once we have clinical version, that is norms, validity scales, that would be a year from now potentially. So again, we are looking at something in the neighborhood of an hour, probably less, and also measurizable, but we don't have that yet.
And another question in the chat is, why is asexuality included in the HiTop model?
Asexuality refers to lack of libido, effectively. This is like, the question is this within the domain of psychopathology? And that, I think, gets at fundamental question of what is psychopathology. And I don't personally think that I can answer that in a way that it's a philosophical question. Personally, I'm not a philosopher. I go with the data in the sense that what goes together with other skills of psychopathology, what goes together with poor functional outcomes, we consider, and that sort of doesn't mean that people scoring on a relatively high on a given scale, first of all, form a group that is called actively distinct from the rest, that warrants a distinct label. Rather, it indicates a dimension of difference between people that can be clinically informative. So we're not. That's where we benefit from breaking away from categorical definitions, where people put in the bins and given labels with unfortunate consequences of stigmatization. We talk about dimensions that we all share, and we have a different sort of a degree of predisposition, and we also vary from day to day in terms of having good days and bad days in terms of our psychological functioning. And they are only probabilistically related to real world consequences, such as unemployment or not having fulfilling relationships, etc. And so I would say HIDA profile by itself is perfect, even elevated, is perfectly compatible with adaptive functioning. So by itself, having high levels of HIDA constructs is not the full diagnosis. You do want to assess real world functioning. You do want to assess participants' own concerns. And if there is, let's say, elevation on reality distortion, things like hallucinations, delusions, perhaps even to frank intensity, but the person is happy with the delusions and it's not getting them in any kind of trouble, that may not be a target of treatment whatsoever, but maybe an information for you to have in mind. So let me underscore here that we may have some constructs that may sound wonky. They may also have to have constructs that, how to say this, that do not mean what they sound like, because one word doesn't capture them all. But the fundamental point is that this is the dimensions of individual difference as opposed to categories, as opposed to necessarily psychopathology.
There's a similar question in the chat about adaptive traits. And so have there been any thoughts about a high top model for adaptive traits or including it in the existing model?
Aiming to talk about psychopathology, and what that practically speaking means is that we're interested in distinguishing people who are very high on a given trait, let's call it that, versus moderately high versus slightly elevated. And so that means that basically we are not really assessing well like 85% of variance in the general population, let's say on something like detachment. And that's a sort of tactical limitation in a way that if we did, we would have to have much longer measures. And so this is not, I think, philosophical position. This is not something that is set in stone. The opportunities for further development of the opposite end of these measures. You can get some information about somebody functioning or having very good psychological functioning by scoring very low on height-up scales, but really they will not be very precise at the low end, at the adaptive end. So if you're really serious about adaptive functioning, about protective factors, that we want to do further measure development. So that's an invitation for everyone who's interested to sort of take perhaps height-up SR and maybe a height-up model overall as a starting point and get into that other adaptive end of the constructs.
Will the high top SR include protocol validity indicators? And if so, could you describe those?
Yes. We don't have a plan worked out yet, so I unfortunately cannot say anything with confidence today. If you had Len Sims in person, I think he'd have a couple of ideas, but I don't know what Len is thinking.
Is the high top questionnaire, or will the high top questionnaire be available in Portuguese? And maybe you could just talk a little bit more about plans for translation into other languages as well.
So the measure development group decided to have a subgroup of people interested in adapting HIDA-PSR and other resulting instruments, but HIDA-PSR is a one that nearest to completion to other cultures. That involves adapting it to different languages, but not only. And the group has not met yet, has not laid out the protocol, because we're still working on finishing HIDAPSR self-report. Once we done that in the next couple of months, that will be next big item on the agenda. I cannot say with confidence what the protocol will be for the measure development, but I would say that I'm pretty sure it will be more than just translating and back translating the instrument, just because we know that results in many problematic items. And sometimes the problems are so significant you can't even, it's not like you're not measuring construct particularly reliably, you're not even measuring the right construct. That happens much more rarely, but it can happen. And so I think this process will involve some level of data collection. So to take a HIDAPSR and bring it to a new culture will not be a matter of weeks or even a couple of months. It will be probably a matter of months, many months, but the specific protocol will be coming, I hope, in the beginning of next year, 2023.
And what about a version for children and adolescents?
It's, to me, the same kind of question, that the way that translating or adapting instrument to a different culture, to a different language potentially is the same sort of challenge as to adapting to a different socio-demographic group. So, for example, or selecting age-appropriate items, if in some ways is similar to taking an item that is right now written in English and expressing it in Portuguese. Conceptual challenges, psychometric challenges are there, and we cannot simply assume that we can swap one kind of behavior for another behavior and it will work. We would have to test it psychometrically. So that will be a charge of this adaptations group, I think, to go to basically to youth samples. But we will need more people, more participants in this process that we have now. Pretty much everyone who worked on HIDAPSR really is specialist in adult psychopathology. So if you're a specialist in adolescent or childhood psychopathology, I hope you'll join the process, perhaps even lead some of this adaptation.
And I think that this is a topic that I think Dr. Nelson is going to cover in a little bit, but just if you have any thoughts about it too, do you have any insight or previous research on the benefits of psychoeducation advantages or concerns, the HITOP model?
For psychoeducation, I don't think we have any hard data. There's a paper that's online, will be coming out in American Psychologist, where it's basically it has in the title translating promise into progress, 10 questions for research on HITOP, effectively. So 10 questions paper covers 10 topics on where that's Chris Conway led this effort with Avshalom Kaspi, Bob Kruger, and myself. And one of the topics, so check out the whole paper, it's online, but one of the topics is about education of trainees. That's a bit different, of course, from psychoeducation. And we've put some hypotheses forward that we think it will work, but we don't better, that is, than DSM diagnosis, but we don't have the data yet. So I will save this question for Brady.
And the next question, a lot of individuals who are not covered in the clinical diagnosis at present will be able to get a diagnosis under any HITOP dimensions, but then do we have treatment interventions for individuals or a group of problems referring to a subspectra?
Yes, so the question, I think, is that if you have a patient client presenting is a need for treatment, or at least seeking services, and HIDOP profile is above, let's say, t-score of 65, that is 1.5 standard deviations out, yet the person is not meeting criteria for diagnosis. Please correct me if I got this wrong. So this scenario, I think, fundamentally is no different than before we have a HIDA profile for the person. So there is a person needing treatment, and DSM can't capture them, calls them subthreshold, or perhaps has relationship problems, what used to be V-codes as opposed to full diagnosis. So I don't think the kind of administrative issues here really change, unfortunately. Fortunately, we may have more of a clue based on the profile and what's elevated as to what issues are. And so, yes, a person may not, let's say, meet the criteria for generalized anxiety disorder, just to pick an example, but is relatively elevated on trait anxiousness. So again, 1.5 standard deviations, almost there vis-a-vis JD, doesn't quite have all the symptoms needed, or something like that. That we can make an assumption, test that assumption, basically make a hypothesis that effective treatments that we know to be efficacious for JD would translate here. And it is early state of the science that we don't have randomized clinical trials specifically for high-top constructs. That I'm sure will come through in this entire workshop. That what we know is sort of taking from diagnostic categories and working it back to more dimensional constructs. But as we continue this research, and those of you who are in academia, I strongly encourage to consider such studies. And there are some already, such as a unified protocol that where the targets are dimensional, and but in any case, as a clinician on the front line, you're not going to do a study. You need guidance, and so the best guidance we have is sort of crosswalks between dimensions and the extremes and the diagnostic categories, which allows us to project that the treatments that are efficacious for these extremes may be efficacious for somewhat moderate manifestations of psychopathology.
There are two related questions. How come there is only a detachment subfactor rather than a detachment attachment subfactor? What about psychiatric conditions where patients suffer from problems associated with being overly attached? For example, codependency, which is an official diagnosis, but certainly is observed clinical phenomena, dependent PD, separation anxiety. And then the related question is, can psychopathology emerge on both ends of each dimension? To be extremely high or extremely low on any spectrum could be non-adaptive.
Well, all questions have been really interesting, but this one I'm most excited about because there is a lot to think about here. So to begin is detachment is not really interpretable in terms of attachment theory. Just to be clear, this is very descriptive. It is about needs for affiliation, expressivity, very behavioral. Then for attachment as in we do have dependency in the model, and it is sort of an internalizing domain, but further research may establish it as a separate spectrum. But at this point, it has not emerged as such. So it's on a lower level of internalizing. So it is covered. It is important, and overall, and it is not opposite of detachment. Right, the opposite of detachment is a person who is very gregarious, very proactive. They have no trouble with sort of setting up plans and vigorously pursuing them. They always have rewards, especially social rewards, that are driving them. It's theoretically could get into something like mania, but we really don't see that connection for detachment. There are other traits where we can see both ends to be maladaptive. And it's been measurement challenge to really construct such measures where so let's say sleep, for instance. Uh, Insomnia and hypersomnia are two ends of one construct, and in principle, both are a problem, both reflect dysregulation of psychological function, but they are not perfectly opposite. Like if you ask people, do you sleep too much? You don't ask them number of hours, but you ask them, for you, do you sleep too much? And then in the separate scale, you ask them, do you sleep too little? These scales you would think would be correlating -1. In fact, they're basically uncorrelated because some people endorse only one or the other, but some people endorse both. And what perhaps they're thinking is, some days I'm sleeping too much, other days I'm sleeping too little, or I'm sleeping too little, I'm sleeping too much, but I still not rested. Hence, I'm also going to endorse sleeping too little. The point is that this dysfunction aspect, of, at least perceived by the person, their subjective assessment of dysfunction, overlaid on actual construct, makes that like basically once you get to pathology, forces the two ends of the construct to no longer be opposites. I don't know if that makes a lot of sense. It's a sort of a measurement challenge that has been a real thorn, but others, like Tom Vidiger, are more optimistic that we will be able to measure overly adaptive end of dimensions, but so far has been a really tricky challenge.
I wanted to note that there were several questions related to diversity in the high top model. And with only 4 minutes left for Q&A, I don't think we have time to get into a lot of detail about that very important topic, but I do want to note that we have a full session dedicated to that tomorrow. And I think that might also be a good, if you have more questions about asexuality, Dr. Rodriguez-Sayas could probably address that as well in the presentation tomorrow. So I don't mean to put that off, just that it's such an important topic. I don't think we should try to address it in just a couple minutes.
I do want to mention that there is science on this within a high-up perspective, and I assume Craig will cover this as this is, but I can also refer folks to our new paper just this summer in psychological medicine, which covers a variety of topics vis-a-vis high-up, and one of them, so hence very abbreviated treatment, is differences and applications of the model in different socio-demographic groups. And so far, it looks like at least the structure of the model is consistent. Now, that's just step one, to ask, like, is the model valid for various subgroups? And we need more data there. There are a very limited number of studies, but studies that we do have say, yeah, model seems to work. The question is, how do you administer treatment and just conceptualize cases given the model and the really different context of different socio-demographic groups? And there we need a whole hour for sure.
There was a question about whether we are interested in having other researchers with specialty, in this case specifically in translation, interested in participating in the high top consortium.
Well, the clinical translation is a work group that David and Camilo co-chair, who is effectively sponsoring this workshop, made it happen. So those who are interested in participating can participate in two ways. David, please expand on this if I don't elaborate enough. One way is as members of clinical network, and that one of the ways to participate is to use something like HiTap.dat. We certainly have a lot of infrastructure for HiTap.dat, but that doesn't have to be to help us collect data, or either quantitatively or qualitatively, about how this is working, this dimensional diagnosis, how it's helpful for treatment, where it faces challenges, and not only treatment, prognostication as well, communication with patients, with other providers, etc., etc. So that's one way to participate. Another one is to actually, if you're a member of the consortium, to join the work group and write papers, etc. So I will encourage everyone with such interest to contact David. He as our host.
Yeah, and to reiterate that, so if you have expertise in an area that you think HiTop could use you, we are definitely interested in collaborating. And just to go back to the diversity question too, I think that's a particular area where, well, we would definitely welcome more participants and more ideas into the consortium. So if you want to join the consortium or want to participate in any of these projects, contact me or contact Roman or Camilo or any of the other presenters, and would be thrilled to work with you. Well, I'm sorry we didn't get to all of the questions on the chat. I think a lot of them are going to come up in the next presentation and the